Hello, everyone, and welcome to another RadCast webinar. I'm proud to be joined by one of our alumnus. I always forget what it is, Dr. Alex Bow, who was part of the application course back in 2023. He's now a successful ST1 radiology applicant. Congratulations again, Alex. What we're going to do in this webinar, like we did previously with Craig, is kind of demystify the MSRA. Often a lot of candidates speak to us and say, Mohammed, Uzi, Jamie, how do I smash the MSRA? The problem is we haven't really sat the MSRA since like 2018, 2017. So we're kind of outdated with what we know about the application from an MSRA perspective. So that's why we get candidates like Alex, who absolutely smashed it. I'll let him explain his own preparation, his own scores, and how we kind of took the exam head on. And then, of course, what we've done is we've also taken information from other candidates who were successful and put them onto our application course. The link is in the description below. But let's get started, Alex. So over to you, Alex. Do you want to introduce yourself?
Hi, so my name's Alex. I'm an ST1 in radiology in Oxford. Before radiology, I did F1 and F2 in East Anglia, and then I did a teaching fellow job in Coventry.
Thank you. Thank you so much, Alex, for using your Friday evening to chat with us about the MSRA. I presume you wanted to forget that exam, but here you are back again with the MSRA. So like I said, Alex was part of our 2023 application cohort. We supported him with the application process. How are you finding radiology so far, Alex? Bells and whistles, everything you hoped for and more?
Yeah, it's been really good, thank you. We've got 10 radiologists and one nuclear med in my cohort. We've been very well looked after, really nice vibe in the department. Everyone's on a first name basis and really great consultant to trainee ratio in our sessions. It's been really good so far.
So if that hasn't sold radiology to you as a career, I don't know what will. But what Alex is saying is not unique in terms of just his training program. It's kind of universal when it comes to radiology. It's a very small cohort. It's often one-to-one, very kind of first name basis, as Alex put it quite eloquently. And you're a trainee in first year, like definitely you feel like a trainee. Everyone is trying to teach you physics, anatomy, radiology, reporting. It's really nice the first year. I remember it quite vividly. You're like a medical student, but you're getting paid. That's how I remember my first year. So before Alex goes on to teach us his get rich quick scheme about the MSRA, in your application year, Alex, how was the MSRA used?
Yeah, in two ways, really. The first way, most importantly, is that it's the only factor used in the shortlisting for interview, or at least it was. And that was a set cutoff score, and I think it was around 555 last year. We can maybe chat a bit later what the scoring actually means. And the second way is that it's used as part of the final mark for the whole application. So in my year, it was 20% of the whole mark, which is actually quite a lot. So not to be neglected, but of course, things can change.
Yeah, I think that's the key thing that Alex has mentioned. Things can change. So for Alex's year, 2023 to 2024 application cycle, as Alex correctly said, it was 20%. That is less than what it was previously, but as Alex is trying to emphasize, that could change again. It could go down again. It could go back up. It just depends on what the application invigilators or people involved in setting the application can determine. And similarly, I think one of the key takeaways is it's used to shortlist you for interview. I emphasize this so often when people get in touch with us at RadCast. Oh, I'm doing so much portfolio prep. I'm doing this and that. And then when I ask, have you done any MSRA? They're like, oh, no, I'm going to leave that till the end. I'm like, well, you may get full marks in your portfolio. You may have a PhD. You may be having teaching coming out of your ears. But if you don't get shortlisted, nobody will ever know about this. They don't even look at your portfolio. It just literally gets put in the bin because, as Alex said, the MSRA will determine if you even get to the portfolio review stage. So just to summarize, Alex's year, 20% of your final rank, and similar to previous years, used to shortlist you in terms of getting to, number one, the portfolio review stage, and number two, critically, the interview stage. So when you applied for radiology on Oriole, Alex, what then happened in terms of the MSRA once the application window closed?
So yeah, you submit your application around November, and together when you make your account, you'll be given an Oriole PIN, and that is linked to a Pearson VUE account. So you have to go onto Pearson VUE, which is the same place you take your driving test theory exam. So you go on their website, make an account, and then in mid-December, I think it was, you get an email saying that the booking is open. You're also told what day it's going to open, I think, on Oriole or via email. So the thing is, they will email you what to tell you it's open, but it may well have opened several hours before. So it's definitely worth checking and be checking with other people before they email you at 4:00.
Yeah, that definitely hasn't changed. I think every year, every candidate says the same thing. I'm so glad that I was with other colleagues applying because they message saying it's open. And then randomly at 4 p.m., you'll get an email from Oriole saying, oh, bookings are now available. And then when you check the dates, they're all gone. So it's first come, first served. Is that correct, Alex, in terms of booking?
Yeah, it's first come, first serve. And the actual window is around 2 weeks. And you should probably, if you've got time, try and book later in the window because it just simply gives you more time to revise.
100%. That's a good strategy. Just try and get the last day or later days so you can just have an extra period of time to revise. So you've booked your exam. It's now exam day. You go to, as you said, the Pearson VUE Center, which is where you probably sat your driving theory test. What then happens, Alex?
So yeah, I got quite a local slot within walking distance. And I think the test was around 8 a.m. They may have afternoon sessions. This is like in the bleak midwinter at 8 a.m. And
pitch black. Pitch black.
Yeah. And I got there early and there's just a queue of people waiting outside. So, probably just get there on time. And so you check in, you give them your ID. It's quite a formal environment. You have to sort of put all your bags and coats in a locker. As I said, other candidates were there too. Then you walk into the room, you log on, and you've got some instruction screens there. And then when you're ready, you start the exam.
Okay. So you've started the exam. In terms of sections, all of you face the same section first, or is it some will get the professional dilemmas, others will get the clinical problem solving?
That I'm not sure of. I think I had professional dilemmas and then clinical problem solving, but I think it probably could be the other way around as well. Okay. I don't think it's always one or the other.
And how did you find the different sections? Like, how would you describe them? Like, what are the differences between the two?
I would say they're both kind of time pressured. They're obviously different lengths as well. There's 5 minutes in between if you want to take a short break, which I probably would advise you do just to decompress. Just put that last
mentally
exam
prepare yourself
to the next section and get in the mind frame of the next part.
What did you prefer in terms of sections? Did you feel more comfortable with one than the other?
I think I felt more comfortable with the clinical problem solving, so the medicine part, because you've got that knowledge to fall back on, whereas the SJT is a bit of an unknown and there is kind of subjective elements to it. So I'd say I was more comfortable with the clinical problem solving.
I think you're reiterating a lot of candidates tell us, saying that with the clinical problem solving, you can kind of prep because the more questions you do, the more reading you do, the more guidelines you learn, it just kind of reinforces all that knowledge. Whereas with the situational judgment test element, the ethics, the scenarios can throw you off, answers can throw you off. And it's just kind of like, well, who's right? Because that's one of the big things I always struggled with when I was prepping. I was like, well, if me and Alex put it differently, how do we know I'm wrong and he's right, or vice versa? So I think everyone that we know always says the clinical problem is like the safety blanket for them. So one thing that we get told, or one thing that we read when we read around the MSRA kind of like curriculum or the theory behind it, is that they often say it's claimed to be at the foundation year 2 level? Because often that's when you apply for your specialty training, whether it's radiology, GP, psychiatry. Based upon your experience, would you say that's true?
I would say the difficulty of the question is probably at F2 level, but it's such a broad exam that you'd have to have done all the specialities for that to be completely true. Like I say, it's very broad, so you'd have had to do your obs and gynae, your peds, the GP placement, all the rest of it. So you're not necessarily going to cover all of the topics by doing the foundation program. So you really do have to revise.
Fine. And talking about revision, I often hear this a lot. Something we plead with candidates to get this out of their head. They're like, I don't need to prep. It's like finals. I'll just quickly read about it in the last month or so. Personally, I think that's a lot of nonsense. Do you think it's like finals, or do you think it's a bit above finals?
I would say it's probably a bit above finals. And I think if you think, it's all med school content, you risk lulling yourself into a bit of a false sense of security. I think, as I said, the exam is so broad, so you'll need to know some ops-val, you need to know some hematology, and that's probably gone out of your head by the time you get to the end of F2. Like, you're not going to remember all the causes of red eye at the end of F2. It's just you will have put that to bed, and you'll have learned more procedural things in your day-to-day job rather than keeping on top of the theory stuff.
Yeah, I think if the exam was a test of TTO speed, you probably would all smash it at the end of F2. But like you said, it's not about medical school final level, because you don't do that in foundation. You kind of, I think I remember when I started foundation, I was like, what the hell did I do for 5 years of medical school? Where's all that knowledge? And as you said, you're getting kind of used to the life as a doctor in the NHS. So yeah, I think if you're listening and watching this, please do take Alex's advice. Like, don't neglect the content. It's a lot of breadth and stuff you may have not covered for potentially 2 years since you graduated. So if we were to break it down, Alex, in terms of clinical problem solving and the ethical dilemmas, if we start with, say, the clinical side of it, what was your strategy in terms of revision, resources you used for that section?
Yeah, sure. So I used 2 question banks. I used Past Medicine and MCQ Bank. I know there's other ones available. People talk about Past Test and eMedica and things, but I didn't use those. I started with Past Med first, with just a few questions a day around this time, so kind of August, September, just to ease myself into the process and try and start working through some questions. The good thing about Past Med is that it's got the textbook attached. So if you get a question wrong, the textbook's right there for you to figure out where you went wrong. And it also scores you by speciality, so you can identify your weak spots. And it also has a couple of mock tests, which is quite useful, probably towards the end of the revision process. And then, so I worked through all those questions. And then later on, I did MCQ Bank. These questions are a bit shorter and a bit more similar to the actual exam. And they're pitched at probably slightly higher level than Past Med, I felt. And they also have some real questions used in actual previous MSRAs. So a tip that Craig, who did the previous version of this talk, said was to favorite those real questions and then make yourself a own mini past paper. I guess disadvantages of MCQ Bank is it's a bit less user-friendly than Past Med. It's a very old-style website, so it's quite hard to navigate, but the questions themselves are pretty good.
And one thing that you mentioned just before we started recording, Alex, was an Anki deck. Is that something that you found useful in terms of your own strategy? Would you recommend it for others?
Yeah, so Anki, I don't know if people have heard of it, but it's basically a simple flashcard software. You make your own flashcards and then you can answer them and then rate how difficult they were, whether it's easy, good, or difficult. And then the program itself will show you the ones you rated easy a bit later and ones you rated as difficult, it'll show you them sooner. So the way it works is that it forces you to go over the content that you found difficult. And you can just manually reset it yourself and just go through them. I think the thing with the clinical problem solving is that there's some information in the exam that you just have to know that you can't really work out from first principles, or there's not a logical guideline to follow. So there's just a certain amount of stuff you just have to remember. And that's what I feel Anki is good for. So like antenatal care timetable, there's no rhyme or reason to it. Or at least my knowledge doesn't help me know it. So I made, an Anki deck with however many weeks, and then this is what happens at those weeks. And then you can just learn it. Because it's software, it's also good for visual things like your retinal photographs, dermatology things. And then the final thing I think Anki is quite good for is your extended matching questions. So these are ones where they will give you, say, a list of diagnoses and then a vignette where you have to match each diagnosis to the patient.
Okay.
And so say you're looking at dysphagia or something, you can have a deck with all the causes of dysphagia and then the clinical features. And so you can just make those associated by doing that Anki deck again and again. So I would say the EMQs, or extended matching questions, are probably the harder part of the clinical problem solving paper. So that's why I think Anki is quite good.
No, I remember getting to grips with Anki back when I was prepping for the FRCR part 1. And it was so good, especially for the anatomy, because I just take the image, put it on the Anki deck, and then just go through them over and over and over again. And you can blitz it. You can even get an app on your phone. So you can do them, say you're at work, you got a bit of time, or you're like commuting. And I remember still using Anki for my 2A exam and also for my 2B exam. So it really is good. And space repetition really does work. There is evidence behind it. But it does take investment to make in terms of the time. You've got to be committed. You can't just make 100 cards and then not look at them, because that defeats the whole purpose of them. So I do agree it's a really useful tool. And of course, Past Medicine and MCQ Bank, we aren't sponsored by them, just putting that out there. If you would like to sponsor us, we'd love to chat. But as of now, we are not sponsored. But that's what we hear time and time again. MCQ Bank, really good for similar questions in terms of the real exam. And Past Medicine, because of the fact you've got this textbook that you can learn all the guidelines, and they're always like kept up to date, which is really good. So we've covered the clinical side, Alex. What about the ethics? What was your strategy for that component of the exam?
So ethics was a bit more difficult for me. And I think we've already said that there's an element of subjectivity to it. And again, I think there's this myth that you can't revise for the SJT, or it's a random number generator, all these things that people say, but I think you definitely can, and you definitely should revise for it. I think the most important resource to SJT would be the FPAS SJT official questions, because I think they're still available online. And they are very similar in the content and the format. I did them, I think, about 3 times just to kind of rote learn the logic that is behind the question. And you'll find that when you do them, you'll just fundamentally disagree with some of the orders and things. But I think the thing is not to get caught up in that too much, not to the exam isn't about winning the moral high ground or anything. It's about putting the answers that the examiners want to hear. Exactly. So I think ultimately as well, all of the content comes back to good medical practice, which is the GMC's kind of guidelines for how we should all be behaving. So it might be worth, I read that and just tried to see what the emphasis of that document was. And that, I think that did help a little bit when I was doing the questions, because it then made me think, oh yeah, there was that section about confidentiality that this might be relevant for. I think I would probably avoid doing kind of question bank SJT questions because they aren't written by the subject experts. They're kind of, anyone can write an SJT question and submit it to PassMed, say. But the logic might not be the same as the official paper questions, and that's what you should ultimately be trying to learn. So I would avoid that, do the official questions a few times, try and figure out the logic. There's certain things that will always be the case that you can fall back on. So there's an escalation order for doctors and the same for nurses. There's kind of rules for prescribing that you would always follow. So you tend to approach the original prescriber, then escalate to your reg and then to a consultant. Those kinds of things you can learn. What the questions will do, though, is draw on multiple themes. So the question might be about, let's say, confidentiality, but it's also about autonomy, or it might also be about maintaining professional relationships or something like that. So a question that seems the same as another one can actually have a bit of a different focus. And that's why you might feel like you've done the same question twice and it had different answers, but it's actually because the question is drawing on multiple themes and you're trying to solve as many things as you can when you do your ranking or when you do your MCQs. I think it's probably worthwhile talking a bit about the different types of questions in the SJT and how you're meant to think about them, because it took me quite a long time to realize where I was going wrong with them.
Sure.
So the ranking questions, the way that you need to think about it is that you've got 5 options and you have to imagine you're doing just one thing when you're choosing your answers. So it's almost worse, like in your head, drawing a line through it or thinking that option's not there anymore. So you choose your best answer and then get rid of it and then look at those remaining and then think, what's the next best answer? So treat it like the thing that went above no longer exists. I have to choose the best thing in isolation of the remaining options. That took me a while to realize, because I think sometimes you think, oh, what would I do in time order?
Exactly.
What's my preference? But it's not. It's more, if I only do one thing, what would I do in this situation? So that's the ranking questions. And then the multiple choice questions is kind of the exact opposite. So those questions, the multiple choice questions, you'll have a list of 8 statements and you have to choose the 3 statements that together in combination will solve the problem. So you're trying to think of how to best solve a problem. So you might get a question like, pharmacist suggests the alternative antibiotic or something. What do you do? So you would say you maybe contact the original prescriber, prescribe the alternative, and document it in the notes. So you can see that together those things solve the problem. Yeah. And those questions are quite hard, but some will be obviously wrong. So you're not going to tell the pharmacist to mind their own business. That's obviously wrong. But check the BNS kind of feels right, but it might not be the best, one of the best 3 options. So I think when you make that distinction, you'll notice that you're getting more of them right when you realize how to answer the question.
In terms of resources, did you use the Past Medicine, MCQ Bank, SJT banks, or was there anything different you used?
So I literally just used the official questions. And then I think you guys do a webinar on ethics, which I used. And I think you gave some top tips for the SJT. And I think when I went through them, I was like, the penny kind of dropped at that point and I realized where I was going wrong.
Right.
And as I said, the SJT is not about being right or like having the moral high ground. It's about, can you put the answers
that the
examiners want and that most align with good medical practice? Because that's
I think you've hit 2 really cool points, which I just want to re-emphasize. A lot of people, when we speak to them about the SJT, it becomes like, well, that's a stupid question. They're all stupid questions. They're all, let's just clear that up. They're all stupid questions. It's not about them being stupid or not stupid. It's about if you were to get that question again in a similar theme, in a similar vein, you can't say it's a stupid question in your exam because you'll get 0. It's like, okay, it's a stupid question, but this is how I would answer this to get the stupid marks. That's the best way. Don't criticize it. Don't badmouth it. It's an exam. Yes, it's not the ideal filtering exam, but it is what it is. You can't cry over spilt milk. And a lot of people, rather than understanding the examiner's mindset, use that time and energy just to belittle the exam and just kind of neglect him. Like, oh, what a crap section. What a stupid question. Oh, this would never happen. Majority of questions never happen in real life. It's not a reflection of reality. It's a reflection of the ideal. What would happen in this ideal, hypothetical, simulated environment. The other thing is, which I really liked how you described, Alex, is with the ranking. Once you've ranked something, imagine it doesn't exist anymore. And you've started the question again. And now there's only 4 options. Don't be like, and I remember doing this exactly myself. When I first approached the ranking, I'd be like, okay, I do this, then that, then this, then that. And I would get them all wrong because I'd be like, what the hell? Because it's not sequential. It's if you were to come to this environment with this scenario, with these 5 options and only these 5 options, what would you do? Now, think of it as if you came back to that question with only 4 options, which would be the best? And do it and do it and do it until you've got 0 options left to rank. And finally, one thing I will share with those of you listening is please don't add information to the question, right? Whatever is in front of you is sufficient to answer the question. Don't be like, okay, is this a consultant, someone that I trust? You don't know. Like, the consultant is drunk in this question. Whether they've been drunk all their life and this is just it doesn't matter. The consultant is drunk, so deal with the drunk consultant. Don't be like, oh, would this consultant sign me off for my portfolio? You're adding things to the question that don't need to be added. So I think what you mentioned, Alex, is really cool. And this is something we put in our webinar. It's principles. We don't like to deal with questions because, as Alex said, the question could be rewritten with a different theme. So instead of autonomy, now it's confidentiality, but a similar scenario. Of course, you rank differently. So we say, okay, principles are this. If you have a problem with your training, here is the hierarchy. If you have a problem with your clinical supervision, here's the hierarchy. If you deal with autonomy, this is how you do it, blah, blah, blah. And that's why we made that webinar in the first place. So I'm glad you found it useful. So you've done the exam, you've de-stressed, you're now waiting for your results. What happens on results day?
So you get told when the results are going to be. And actually, I think it was delayed last year. I think it might have been a few days later. That's the other thing to say about the application process is that things change with no warning and you just have to put up with it. You'll get an email saying the results are out, or someone else who's checking might say, guys, the results are out. I think they're about sort of mid-February, they came out on Oriel. You get your score in clinical problem solving and professional dilemmas. So it gives you the breakdown. And then you also found out whether you're shortlisted at that point. So it's pretty brutal. You just get a number and whether you're shortlisted or not. I remember I was halfway through a taster day when they came out and I was, really happy with my score. I think actually, Mohammed, I think I messaged you quite soon after.
I'm good, fantastic. So you find out not only your score, but do you find out this concept of bands? This is something I've heard other candidates. Is that where you also get told this score is a band 2 or something?
Not in my year of radiology. Okay. I think the scoring for MSRA is really weird. I think the logic is that they get your raw mark, then they draw a normal distribution, they put you on that line, and I think the mean is meant to be around 500 or 250 in each section, with a standard deviation of 40 for each section. So it's it's a pretty brutal exam because there's a
Mm.
cutoff. The mean is 500, and as I said earlier, the cutoff last year was 555.
Yeah.
So for everyone over 500, there's someone under 500.
Mhm.
So you can see how you're
Yeah,
very,
cutthroat it is.
you're very much in the top half and beyond to even make an interview. So
Yeah.
it is,
No,
it is
it
quite,
is. It is brutal. And I remember not only do you get the nice messages from like Alex, you also get the tearful candidates saying, "What do I do now?" And just to emphasize to everyone, reiterating Alex's point, how brutal it can be. Alex's year, in terms of the cutoff, was the highest it's ever been. We project it's going to go up. I don't know how much, but in terms of the number of candidates applying, number of candidates sitting the MSRA, it's going up in one certain trajectory. So it is something you got to take seriously. So with that being said, Alex, what was your final score overall?
I got 608 overall, which was 608, 306 in the clinical problem solving and 302 in the professional dilemmas, I
Blew it
think.
out
So
the water. Blew it out the water. Okay. If I took my score from when I applied, I wouldn't have been shortlisted. That's how you can tell how much has changed since of 2018. So to wrap things up, Alex, final question. If you were to give a series like top 3 tips or top 1 tip to those candidates applying, what would it be?
I would say for this, just put in the hours. Like you don't want to, but you just have to. There's no other way really. I would say number 2, don't wing it. Don't think, oh, it's a random number generator. I just have to turn up and give it my best shot. And you really do just, as I said, have to put in the hours. And then probably finally just expect the unexpected. So everything we've said may well change and the interview format may change. They might say, we're just using the MSRA as a cutoff and not using it for your finals. Anything can happen. But you can definitely improve your chances of getting a training number by just putting in the hours for the MSRA. And if you get a good score, you'll feel better going into the interview. If you know you've got a good score in your back pocket, it'll give you a bit of confidence going forward.
Yeah, you've banked the high score. That's so true. And you said you started around this time. Is that correct, Alex? Like August, September?
I did, yeah. I kind of started doing maybe 10 questions a day, just trying to build it into your routine. And then I started upping that to maybe an hour after work if I finished on time. And then actually I was quite fortunate in that I was only locuming in December and Jan. So I had lots of time to do questions at that point. But obviously if you've got other commitments, family, busy rota or anything, you might need to start earlier. You'll just have to fit it around your schedule.
No, I think that's a very, very, very salient point to end this conversation off with, is that you don't know how busy you will be tomorrow, right? And the one thing I remember in terms of my own revision, I would always say, okay, would future Muhammad be appreciative of what present Muhammad is doing by not doing this question? Even if it's like 10, like Alex said, that's 10 you've got to do, you don't have to do tomorrow. And that's really what it is. It's about endurance, consistency, and getting that stamina up to the actual exam date. And I think that thing of fail to prepare, prepare to fail, because it's one thing we have observed with candidates is they like to collect portfolio stuff. It feels nice to get that audit certificate, that taster week letter. Revising is tedious and it's difficult when you're now working as a doctor. You may not have the luxury of locuming, so you can adjust your hours. You may be on a horrible rota like A&E, or fortunate to be on a nice unbanded rota, potentially like in GP or an academic block. So whatever time you have now, just start. Even if it's one question, that's one question you don't have to do tomorrow. Because really, point number 2, don't wing it. Please don't. Because the worst thing you can do is build up this nice portfolio, build up all these experiences you have. You will be so enthusiastic about radiology, but nobody will ever hear it because you didn't get to interview. And fundamentally, once you've got a really good score, like 608, that's amazing. I would be whistling into my interview, okay? Because I know I'm already ahead of my cohort. I just need to just be confident in my interview, and it really does help. So thank you again, Alex. Really appreciate you using your evening to come and chat to us. If there's any comments or questions, please leave them in the comment section below. We'll get back to you. If I can't answer, I'll ask Alex, and hopefully he can let me know what the correct answer is. But yeah, please leave a like, subscribe, and we'll see you on the next video. Take care. Bye-bye.
Bye.